right, I'm going to kick off and introduce Rod Kay, who is Mega Medical's Commercial and Service Director and has been there for close to 30 years. He has extensive experience in the medical device industry. This includes a decade with Smith and Nephew Surgical, New South Wales, Orthopedics and Endoscopic Technologies, 16 years with ConMed Corporation managing pneumatic, electronic orthopedic capital equipment across Australia and New Zealand, including being a member of 3 international product design teams, followed by 2 years with Pentax Medical as ANZ Service Director with flexible endoscopy and hygiene reprocessing. Before moving to Mega Medical to support 100% Australian-owned business. Rod, feel free to add anything that I might have missed. Please drop your questions as you think of them into the chat. We will get some time at the end of the presentation to work our way through all the questions, but I'll hand over to you, Rod.
Okay, great. Thanks, Michael. I'd first like to start that this is a presentation we also provided to SMBE in Albury in March this year. And it's about the reduction of nitrous oxide based on New South Wales health guidelines. So covering quickly, there we go. So the agenda is the guidance itself and why it's been issued, how it affects new builds and existing builds, and then the implementation of the guidance, planning, identifying, testing, acting and reviewing. So first and foremost is the question why. As of October 2022, nitrous oxide was reclassified as a Schedule 6 poison to the general public, and it's always been a Schedule 4 medication. So obviously there's a far higher prevalence now and far higher focus on its use, its misuse, and ways of minimising its use across the general public. The other reason is also exposure. So there's lots of different subspecialties and perioperative and clinical staff that have exposure to nitrous oxide on a day-to-day basis. And the guidance is currently sitting at 25 parts per million during weighted average of an 8-hour shift. So these are the little things where there's steps that the government's trying to make and New South Wales Health is trying to make to minimise that exposure risk. The other aspect as well is the environmental factor. So when you look at nitrous oxide, it's depending on the literature you're looking at, it's between 270 to 290 times the equivalent gram of carbon dioxide in the environment. So obviously as a greenhouse gas and the greenhouse weighted potential, any mitigation they can create to limit its use is a benefit to A, the health industry, and B, the environmental and sustainability piece that most customers and most sites are looking to maintain. So the guidance and planning, there's a lot of overlap between existing and new facilities. New facilities aren't necessarily greenfield sites. They also incorporate redevelopment. So it's one of those things where a new facility, if you're revamping a ward or an area of a hospital, it falls into that new facility, even though it's an existing build. But in terms of the different areas you need to look at, number one are the KPIs. So there has to be a level of tracking and monitoring, system mapping of the existing pipework for nitrous oxide and how you can decommission areas of low volume and low usage. They're not saying that you need to completely decommission all reticulated systems. However, they are saying that you need to be pragmatic in the approach. There's obviously high usage areas like maternity, pediatrics, where it's still a requirement. And it's just looking at if you can decommission the other areas where it's not relevant and only focus on the areas where it is in high use. Because obviously the less pipework you have pressurized, the less chance there are for leaks. The other thing they're looking at is alternatives. So if it's an existing build, can you trial portable cylinders? If it's a greenfield site or a new facility, are you considering the storage requirements and the manual handling processes if you go with a portable nitrous oxide solution? The other thing they focus on is the LHD service level agreements. So it's one thing that they're starting this process and starting this journey. The other thing is to bear in mind when service agreements are being put in place, there's a consideration to the various aspects of this guidance when you're looking at your vendors, whether they're gas fitting vendors, whether they're HVAC vendors, because everyone plays a little part in these reductions across the whole of a facility. Okay, so the hardest bit is the starting point. If you're going to start this journey, you need to make a line in the sand somewhere. The current expectation from New South Wales itself, which is a little bit vague to a certain degree, is a 5% reduction in emissions per admitted patient per annum. So that's end of financial year. They're not saying if it's admitted patients using nitrous oxide or just the general number of admitted patients per site. However, that seems to be the starting point they're expecting people moving forward. So pick a date, pick a line in the sand, and then start moving forward from there. Because obviously, to show any reductions, you've got to have that data up front to say, this is our starting point. We're using, for example, 1,000 litres per year. Next year, we're going to use 950 litres. So it's one of those things where there's not necessarily a correct answer from site to site. Everyone will have a different method of how they're going to track their progress. But these are the considerations when you're looking at it as a bigger picture. So in terms of usage tracking, there's 4 recommended methods. And again, this comes down to your site, the availability of staff, the different methods. So the discrepancy method relies on having your procurement team work out the actual volume of nitrous oxide purchased per month or per week or per day versus the clinically admitted volume. So this is one of those areas where it takes a little bit of work and it takes multiple departments, but that's the discrepancy method is probably the most straightforward method in small sites. So day surgeries, little clinical rooms, procedure areas, dental areas. The cylinder weighing method might be a more beneficial way of doing it, where you might only have a limited number of bottles and you detect the change in weight over a particular period of time, whether that's over 24 hours when it's not in use or whatever it may be. That's how you start to calculate if there's any leakage or any loss in your system. The pressure testing method is a similar idea, but on a larger scale. So you have your pressurized nitrous oxide circuit, and when it's not in use, you pick a period of time and then identify if there is any loss of pressure over that time, or if there's any gas escaping. And that's one of those methods where you can actually identify relatively quickly if there's a leak and start the process of addressing the leaks and minimizing them. The other is the flow monitoring method, which is, again, it's a trickier one because it involves having flow meters in the circuit, so you can actually verify from point A to point B to point C how much nitrous is being used and if there's any variance in that between those points. So they're some of the different methods for usage tracking and actual loss of leakage of nitrous oxide. But again, it's working out what's best for your specific facility, because obviously in a large site, some of these things, there's no chance of using a cylinder weighing method. The discrepancy method, if you've got 8 different procedure rooms running, might be a challenge as well. So again, The guidance isn't dictating which one you should use. It's just giving you various options on how you may want to proceed with it. The other thing is exposure tracking. So as we've talked about in my earlier slides, it's 25 parts per million weighted over an 8-hour shift. And chronic exposure has been linked to nerve damage and liver damage. Obviously, it's not day-to-day volumes. We're talking high levels of exposure. And it's one of those things, anything they can do to reduce that is beneficial to all of the clinical staff. And it is a focus of the various specialties. So the RANZCOG, the Royal Australian New Zealand College of Obs and Gyns, ANZCA, which is College of Anaesthetists, they're all releasing guidance to their individual college members on how to minimise their exposure as well. So from a individual basis, there are options out there in the market and available to people. So Medcare and QED, for example, have nitrous oxide monitoring systems where you, in the case of Medcare, it's a clip-on device where you can just put it on your staff, detect the volume of usage, and then you can work towards how best to minimize their exposure. The other option, the QED, is literally a box that sits in the room and it checks on a regular basis. So they're some of those things that are available in the market that are helping steer people towards these solutions and how best to minimize exposure. So some of the most common sources of nitrous oxide loss, and these are the things which overlap. So it may be engineering, it may be the HVAC team, it may be the actual clinical staff that can help minimize usage. So number one are the gas outlets. All of the gas outlets have a scheduled maintenance routine. So whether it's annual inspections or whether it's replacement of O-rings every X number of years, ensuring that level of maintenance is being performed minimises potential loss of gases from the outlets themselves. Internal pipelines and bulk gas source connections are one of those more tricky things where it is an engineering challenge. They have to look at where there may be leaks. Obviously, the challenge with nitrous oxide is it has no real smell, it has no real taste, and it's clear gas. So to actually detect it is a bit of a challenge unless you can physically hear a leak. One of the other things that's a more common aspect are loose hose connections. So obviously in highly mobile equipment like anaesthetic units and your demand valve units, when they're being moved around, the threaded hand wheels can slowly work their way loose. And it's not necessarily enough that you'll hear a loud hissing noise, but it's enough that the gas can slowly escape. The other aspect of that is with mobile units, if they have gas bottles, making sure they turn the gas bottle off when they're finished using it, because at the end of the day, when you depressurize the circuit, there's less potential for any leakage. So equipment checks and testing are another area where there is potential to reduce the use of nitrous oxide, and this comes down to the individual anaesthetic equipment vendor. But there's level 2 and level 3 checks that have to be performed with an anaesthetic unit every day. So level 2 check at the start of the day that all of the circuits and all the functionality is there. Level 3 before each patient. And it's a case of, is there a scavenging system? Are they using the minimum amount of nitrous oxide that they need to use for the test? Or is it just a generic turn it on, check the system's running? So if there's a way of improving the best practices at the site to minimize that, that's another area where losses of nitrous oxide can be investigated. In larger sites and operating theatres, pendants are obviously a very large source of leakages because they use flexible hoses that can be anywhere from 5 to 10 meters long, and they're always moving. So the fatigue on them, the connection points, all of these things have far higher chance of leakages occurring. Lastly, are the incorrect and inefficient scavenging systems. So when you're using nitrous oxide, obviously you should have a scavenging system to reclaim or rebreathing unit. But is it being used correctly? Is it fitted to the patient correctly? All of these little things also affect the amount of nitrous oxide being lost to the environment and surrounding air. So these are some of the aspects that need to be considered as a part of the bigger picture of this guidance. So in terms of actions, adaptation of your existing systems are probably the very first starting point. So the direction to eliminate piped or reticulated systems, again, it's for low usage areas or areas where it's deemed to be unnecessary. The guidance also recommends to exclude reticulated systems in new builds where possible and move to the portable solutions. Again, it's one of those parts where you need to consider this during the design and development stage, not once the build's already done, because then it's too late and you have to work backwards to try and find all of the different aspects. Like, where are we going to store them in the bottles? Do we have enough space? Are the staff trained in how to use the portable systems? The shift to the point of use and cylinder-based supply, that's the preferred method. So if sites can trial portable cylinder delivery options, that's probably going to be the most beneficial, because it's a very, very limited access. You can physically see the number of bottles. From a procurement standpoint, they can monitor the usage and monitor the purchasing patterns, and then try and work towards ways of minimizing the usage across the teams. New facilities, this should be the default option. Obviously, it comes down to the individual site and the requirements of the site, but the guidance is making this the default for any of your greenfield sites or any of your redevelopments. So hopefully people will start to focus more on that and consider it more when they're working through the design phase of a new build. One of the important bits is maintenance of the existing systems. So every medical gas device has a maintenance schedule. It has an inspection and testing schedule, and unfortunately, it always gets, or not always, but in a large number of cases, it gets bumped down the list of priorities when there's a limited budget and things need to be done. People will put it off until it's a time when they're coming up towards accreditation. So obviously, keeping on top of your maintenance schedules and making sure everything is tested and functional is probably going to be one of the best ways of starting a journey of minimizing the nitrous oxide usage and loss. Because if the hoses and the devices are functioning correctly, there should be no leaks from them. If the outlets aren't leaking, again, it minimizes the number of points of egress for the nitrous oxide. And the pipeline systems themselves, again, more of a challenge, because obviously they're not highly visible and they're more challenging to get to. But if you can decommission areas that aren't in use and cap them so they're no longer available or no longer accessible, that's probably going to be one of the best methods. In terms of considerations, it varies from state to state. So obviously in New South Wales, any of the pipe work, you need to have a gas fitting license. You want people that actually know what they're doing and are accredited by the various manufacturers to do the testing or to do the repairs, because it's one of those things where people have a broad range of services and they might not necessarily be as skilled in one area as another. So ensuring that the vendors you're using do have the capabilities and they are accredited by the manufacturer to do the work they're providing for you is one of those things that makes life a lot easier and it reduces the risk factor of things going wrong. Education and training are another really important aspect. And this is a section where it's not the engineering team, it's not biomedical specifically, but it's a whole of facility aspect to how they're going to improve the systems and reduce their usage. So first and foremost is clinical use. Is it necessary, or is there an alternative method? One of the other things that one of our technical experts always points out is nitrous oxide doesn't work in 100% of patients, and it's more beneficial in pediatric patients than in adults. So it's an aspect where clinical use and the clinical education team should be looking at it and ensuring best practices are being maintained for the staff on how they're going to use it, which patients are most acceptable for nitrous oxide usage or an alternative method of anesthesia or sedation. Confirming your pre and post-operational checks. As I said before, turning off equipment and the gas source after use is probably the easiest way to improve the outcomes for everyone. Obviously, leaving systems pressurized overnight, it has greater potential for exposing nitrous oxide to the environment. Best practice might be at the start of a list or start of a procedure, as a part of testing the equipment, just checking all the connections are tight and skew up. It's a simple twist of the hand wheel to make sure it's not loose, and everyone can move on and get on with their day. Operational training comes down to the specific vendor and specific product. Obviously, with a demand unit, it's already a mobile unit, but it's working out whether it's going to be most beneficial for the patient and whether you're using the right volume and the right percentage ratio. Another aspect is making sure that those scavenging systems are in place and in use, because when things are an emergency and when everyone's rushing around, sometimes they get overlooked. When the scavenging system is looked at as a part of the training where it's every bit as important as the delivery of the nitrous oxide, it's one of those best practices that reduces the exposure risk for all of clinical staff around it. And then in terms of patients as well, if they do have access to the sedation unit for pain management, it's ensuring that once the patient's moved away from the area or not in use, that the gas is turned off as well. One of the other aspects is if you can't necessarily decommission an area, you might want to look at capping the outlets where they're not in use, because obviously some sections of your facility might still require the pipe to nitrous, but you can look at capping the outlets in other rooms or other areas in that circuit that aren't necessarily required. So all of these little steps, again, help in that larger picture. So the other aspect is the ongoing process, and it's the ongoing monitoring and measuring. It's the responsibility. It's a bit of a hot potato because obviously nitrous oxide leakage, everyone looks at it as the pipe work and the outlets and the devices. However, there has to be that interdepartmental awareness and focus to get the cumulative results that everyone needs. So are the perioperative staff, are the procurement staff engaged? Are the clinical education team staff engaged to improve the best practices? Are your delivery teams for the mobile and portable units aware of manual handling practices, best way to move it, monitoring where the nitrous is moving around in the bottles around the facility? The maintenance, have the maintenance teams organised routine and scheduled activities to monitor any leakage or minimise any leakage and maintain the functionality and efficacy of the equipment? Because that's a critical part that the engineering and maintenance teams can be involved with. In terms of staffing, as I've said, the clinical education team, ensuring they have periodic training and education, because there's, in a lot of facilities, there's a lot of agency staff, there's a lot of new staff and staff turnover. Are they ensuring that this training is being put on in a regulated fashion so it covers everyone that's moving into the facility or moving out of the facility? In terms of new facilities, in particular, the installation process. So if there is still the need for a piped delivery system, it's looking at, the unique needs of your facility and where that pipework is going to be mapped and where it's going to run to within the facility. It's also looking at, is there an opportunity to build monitoring systems into the pipework as it's been put in? Are there opportunities for a flow meter at the manifold with remote monitoring? Are there areas where you can insert flow meters through the pipework, so at the valve boxes or at various stages within the system? Because longer term, it makes it easier to monitor, it makes it easier to track any changes if you have those flow meters in various points along the system where you can actually check. So they're the four most common ways and best ways probably to monitor and measure this as an ongoing basis, because obviously 5% year on year, it's an ideal. There's no specific guidance on what happens if you don't meet that 5% quota. However, that's the ideal solution from New South Wales Health. And with that, I just want to say thank you, and I'll hand it over to Michael with questions if we have any from the attendees.